And hello, and welcome back, clinical problem solvers. Today I have the huge honor to discuss with a very good friend of mine. He is a CP Solvers legend. Everyone knows him. It's Kirtan Patolia. And today Amal is also going to present an amazing case to us. We don't know what this will be about. I'm already excited because I haven't discussed for a long time, so it's a huge honor. And also wanted to say huge thanks to Elena and Jimena who are helping us today. And then Kirtan, please.
Yes. Good evening, friends. So firstly, I must say that pleasure is all mine to discuss with Şeyma. We know like she is the DOM queen. So I am keeping my fingers crossed that maybe we will have some DOM component and she will help us figure out the case. And also I wanted to thank Amal for joining us for the first time in sharing the case. So thanks, Amal. I wanted to thank Yusuf as well for giving me and Şeyma this opportunity. And of course, Jimena and Elena for helping with the whiteboard. So maybe I will pass the mic to Amal. Tell us, Amal, where are you coming from? How it has been like at your residency program, and what do you like outside of medicine?
Hi, everyone. So I'm Amal. I'm a second-year resident in Georgia. It's been going well outside of medicine. So I recently started doing Pilates, and I really enjoy it. So I recommend it to everyone. Really excited to present the case today.
That's good. Perfect. Well, in that case, let's start. And I think Şeyma will handle the first aliquot.
Okay, so I'll start with the chief complaint. So we have a 60-year-old male who presented with right-sided abdominal pain and neck pain for the past week. So I'm going to tell you. Oh, you want?
No, please tell more.
Yeah. So the abdominal pain and neck pain have been worsening for the past 1 week. He also noticed some abdominal wall swelling and did report some fatigue, headache, right-sided hand tremors, and coordination problems when he walks. Like he feels that his walking is wobbly and he sometimes falls. For review of systems, denies any fever, chills, cough, vomiting, or diarrhea.
Okay, thank you so much for this first aliquot. It's very rich of chief complaints. So first of all, tackling the abdominal pain and the neck pain. So for acute abdominal pain, we usually have this so-called BIPO schema. So without going to being too specific, so is there any vascular, infectious, perforation, or obstruction? The right-sided abdominal pain also lets us, think about anatomical things. What is on the right side? The liver, also at the back side, the kidney, but also think of other abdominal organs that are close to like the stomach. And also I still wouldn't exclude radiating pain that is coming from the thoracic side. And the neck pain itself, I mean, the patient also has headache. And then again, our alarm signals is incoming. So is there any kind of sign for something like meningitis? Like general headache is very unspecific. This could be secondary to a systemic viral illness, for example. But we have this so-called snoop mnemonic where when headache is like threatening for us, so if there's systemic symptoms, like in this case here, we also have like neurologic deficit for the snoop mnemonic. There's neurologic deficit with the right-sided tremor, coordination problem when walking. So I'm also worrying whether there might be an intracranial process causing the headache or an infection, or is there any systemic viral illness causing this? But yeah, what do you think here, Tom?
Perfect. So I love how Şeyma outlined the approach which we should have when we see somebody in the ED. That first things we want to do is making sure that somebody doesn't have a life-threatening illness going on. So in our case, we have two separate problems going on. Something is in the abdomen and something is in the CNS. Now, they might be related, they might be the same process, or they could be different process. So it's better to approach them individually, and then in the end, we can try to figure out something which is common to both of them. So for abdominal pain, I agree with Şeyma that first things we want to make sure that there is not something life-threatening. So like vascular cause, inflammatory cause, something perforation. It's good to know that in our case, at least the symptoms are not developing over the course of hours, but it has already been 1 week and patient is doing fine. So we can, kind of take a seat back and try to analyze deeply that what's going on. So first thing regarding the abdominal pain is we want to make sure that is this pain solely coming from the abdominal wall itself, or is it coming from inside? Because Amal told us that this patient has swelling in the abdominal wall. Now, if there is swelling, then we want to know whether it is coming from the skin, subcutaneous tissue, fascia, or is it coming from deep inside, like there is some organ involvement, like parenchymal involvement or peritoneal involvement. So that's the first thing. And how would we figure out? So if we get to the physical examination and we find that, well, the patient has profound point tenderness in the region of swelling, and let's say there is some fluctuance there, then we might say that this process seems to be limited to the abdominal wall. Maybe there is some abscess there, some fluid collection there. But let's say there is nothing much going on in the region of abdominal swelling, and surrounding that swelling, you have this profound rigidity and rebound tenderness. Then you might say that, maybe the peritoneum is involved, and what we are seeing superficially is just the side effect of what is going on deep inside. So problem is skin deep and not just like superficial. So that's regarding the abdominal pain. And once we localize that, where is the problem, then we can dig deep into the differential diagnosis. Second thing for the head problem, now that is a little bit more complex because we have tremors and coordination. And we always say that in neurology, something which is very difficult is the movement disorders. It's like there are so many things which can cause tremors and coordination issues. But like at the basic, like if I was a med student, then I would think that maybe there is some problem with the basal ganglia and some problem with the cerebellum. Now, it could be a problem with just one of them, or it could be a problem with both of them. And if there is a problem which is evolving over course of just 1 week, then the differential narrows significantly. So in neurology, we always say that whenever something is acute, we want to rule out infections. We want to rule out the toxic and metabolic causes. So I would like to know more whether the patient has past medical history, which is suggestive of some medications which could cause this, some substance abuse which could contribute to this. And then when we go to the labs, we can look for the electrolyte abnormalities which would contribute to this. But my focus would be to figure out that what can affect the basal ganglia or the cerebellum. And that's how we can make the progress. So Amal, please share more data with us.
Okay, so now I'm gonna move to the second aliquot. So for past medical history, he had a heart transplant for cardiac amyloidosis 1 year ago, and he has CKD. For medications, he is on torsemide, tafamidis, tacrolimus, mycophenolate, and prednisone. And then for family history, his mother has heart disease, father has hypertension, social history, smokes cigarettes, denies any substance use or alcohol use. He works in healthcare and no known allergies. So that's the end of the second aliquot.
Sure. So maybe I can discuss a little bit about the medications, and then I will ask Şeyma to integrate that with everything else. So as we were discussing earlier, that we want to see if there is some toxic cause which can explain at least the tremors and coordination issue. And abdominal pain, we will dig deep once we have the physical examination. So one important medication that caught my attention was the tacrolimus. So as we know, tacrolimus is calcineurin inhibitor, and it is often used in people who get transplants, whether it is renal transplant, liver transplant, or the heart transplant, as in our case. So one peculiar side effects of all the calcineurin inhibitors is actually the cerebellar toxicity. So often when the levels are toxic, people can have tremors, people can have sedation, people can have ataxia. And this is also true for other similar group of medications like anti-epileptics. So I would want to know more whether there was any reason that this patient had medication interaction somehow, or patient overdosed by mistake, and that's why the levels are high or not. And often getting the trough level can help us make that decision. So that is what I'm taking for this aliquot. And then I will ask Şeyma to share her thoughts on the past medical history and social history, if it can explain the presentation.
So first of all, I really loved your reasoning, especially with the medications the patient is on, with, as you said, with tacrolimus and MMF, which are against the T cells. And the general question I'm asking myself, when the patient had this transplant, I heard 1 year ago, like I'm currently in a transplant ward, and from what I have learned, usually within the 6 months, you give them Cotrim for PJP prophylaxis, and you also give them, like, depending on the transplant status, a valganciclovir for CMV prophylaxis, and generally because the patient has these T-cell inhibitors, these patients are prone to intracellular organisms and also fungal disease. So that's something that I have been thinking of. What I also loved about the tacrolimus part is like these calcineurin inhibitors, like we love using them for kidney transplants too. And these are also very nephrotoxic. So these called calcineurin inhibitor-induced nephrotoxicity. Like we use them for transplant, but if you have two, like what I have learned in kidney patients, the TAC, there is this level that we can measure, should be between 8 to 10. So it would be important to know how the levels are. So I would like to measure the tacrolimus. We always measure it. And also what I loved is what AMK mentioned, like patients that are immunocompromised are also prone for something like PRES. And also calcineurin inhibitors, can also cause something like tremor. And general, the patient has a heart transplant is also prone for something like infective endocarditis. So yeah, that's what I have been thinking of so far.
Yes. Amal, you can give us more data.
Okay, so now I'll move to physical exam and I'll start with vitals. Temperature was 99.8 Fahrenheit, heart rate 114, blood pressure 138/80, respiratory rate 17, SpO2 100% on room air. And then for physical exam for general, he looks ill. And then normal cephalic dry mucous membranes, cardiovascular, normal rate and rhythm, normal heart sounds, no murmur was heard. Pulmonary was also unremarkable, no labored breathing, no abnormal lung sounds were heard. For abdomen, there was a 3 by 2 centimeter tender right flank swelling with mild erythema. And for neuro exam, so he had the power was 4 out of 5 throughout his extremities, upper and lower, and had 3+ reflexes bilaterally. We did plantar reflexes, and he had subtle ataxia in the right upper. So he had subtle ataxia as well.
Okay.
And then extremities and skin were unremarkable. So this is the end of the third aliquot.
Okay, so first seeing the vitals, what I'm noticing is the patient is tachycardic, but is afebrile. So I still wouldn't exclude any infection ongoing because this patient is being immunocompromised. And now also seeing this right flank swelling, as you already tackled, Kirtan, what could this be? So any kind of skin and soft tissue infection. So I'm considering, like, depending on how it looks like, if it's very well demarcated, and if erythematous, thinking of something like erysipelas, or could this be cellulitis or even an abscess? So what I would like to do is also something like an ultrasound, which is a very helpful tool to look whether this could be something like an abscess. And if it doesn't help me, also to do a CT abdomen. And then also now seeing there's ataxia in, I haven't heard where, but this also gives me, like, makes me I'm thinking of maybe there is some hematogenous spread of this maybe infectious process that could have gone to the CNS, and especially with the ataxia, as you mentioned, could this be within the cerebellum or within the basal ganglia? Yeah, so that's what I am fearing right now. And also with the ataxia, I still don't exclude possible neurotoxicity due to the medications that the patient is having. What do you think, Kirtan?
Yeah, excellent analysis, Shem. I agree with you that regarding the abdominal pain evaluation that we outlined in the first aliquot, that we want to find out that which anatomical structure is involved, then we can refine our differential. So from the examination, it looks like that the pathologic process is primarily centered in the skin and subcutaneous tissue. We didn't get the flavor that there is like some fluid thrill or some tenderness coming from deep within. Although, of course, the CT scan would be essential eventually, given the immunocompromised status of the patient, to make sure we are not missing anything. But let's say if we believe the examination that problem is in the skin itself, then our job is to figure out that if somebody has acute to subacute onset of skin and subcutaneous tissue infection, and from the examination, it looks like that there is a not skin breakdown and no concern for invasive infections like necrotizing fasciitis, then we start thinking of subcutaneous infections, which would be abscess or phlegmon. And then we have to understand that in common population, what are the bugs which can cause it? And then in immunosuppressed population, what are the things which can cause it? And I guess once you get the more data, we can dig deep that based on the kind of immunosuppression you have, which impacts the B cells, T cells, neutrophils, or macrophages, you can have different susceptibilities to individual infections. So we can go into that once we get the more data. So that is what I'm thinking about, that what kind of infection is sitting there and causing the abscess. Now, if we move to the neurology aspect, then this is definitely more interesting. And it's always difficult to tease apart whether this is coming from medications or is it coming from the underlying process, which, like, let's say infection, which is going on in this patient. Now, one important thing is that usually when medications are implicated in causing ataxia, it is diffuse ataxia. So let's say if somebody tells me that, oh, this patient is ataxic only in the right upper extremity or right lower extremity, then that makes it less likely. Usually all the toxic things should cause the pan-cerebellar ataxia. Although there are exceptions, like metronidazole sometimes will cause focal ataxia, but in general, you will find that it should be diffuse ataxia. So given the fact that in our case, it is focal ataxia, that makes me more concerned about a structural pathology going on. And that is where Shema's point becomes so important, that what if we are dealing with a hematogenous spread of infection, and maybe there is some abscess there in the brain as well, probably in the right side of the cerebellum, given that we have the right-sided ataxia, and not in the vermis, because if it is midline, then we would expect truncal ataxia. So that is what I'm more concerned about. If it was diffuse ataxia, then it would have been easier, and we could say that, oh, it's medication, but it's focal. So I'm more concerned about that. One important thing is that the patient's vitals are looking good. So that makes us think that this is less likely to be probably staph infection. Because if it was staph sitting in your abdomen and causing this degree of cerebellar ataxia by an abscess there, then you would expect literally person to be in the shock, basically, almost always for 1 week. So that makes me more concerned about the indolent infection. And we will dig deep into that once we get the CBC and basic imaging, that what kind of infection we could be dealing with. So share more data with us, Amar.
So I'll just give basic labs now. So for CBC, white blood cell count was 19,100. Hemoglobin was 8.3, but that seems to be around his baseline. And platelets 418,000. For CMP, sodium was 133, potassium was 4, chloride was 101, bicarb was 24, BUN was 34. Creatinine 1.75, and that seems to be around his baseline as well. Glucose 88, calcium was 8.4, magnesium 2, AST was 63, ALT 17, alpha 78, and albumin 2.6. GFR was 48, and troponins were 4. Troponin 4. So.
Perfect. So maybe I can just comment on the CBC, and then I will let the Shema tackle the BMP and CMP. So the only striking thing in our CBC is that patient has leukocytosis and patient has anemia. So anemia, as Amal told us, is probably the baseline. And we sometimes expect this in people who have transplant and they are on immunosuppressive medications. But regarding the leukocytosis, it's a little bit concerning. So of course, the differential would help, whether it's like neutrophilia, eosinophilia, or lymphocytosis. If we assume that this is neutrophilia, and maybe I can confirm with Amal really quick that it was neutrophilia, right, Amal? Yeah, perfect. So if it's neutrophilia, then we are in the category of the bacterial infections and probably some fungal infections. One important thing to notice is that if we are talking about those infections which come in the setting of profound immunosuppression, let's say if this person is on MMF and has pancytopenia, and then you have neutropenia, then you start worried about some invasive molds which can cause infection and which can actually infect the skin as well as the cerebellum, like aspergillus or mucormycosis. But given the fact that in our case, patient has neutrophilia rather than neutropenia, makes us less worried about those category of organisms. So at least we ruled that out. All the bacterial infections are still on the table, but as we discussed earlier, that the invasive fulminant gram-positive and gram-negative organisms are less likely, given the fact that patient has been relatively stable for almost 1 week. So what's the next step moving ahead? So we can do the normal evaluation for bugs, which we do. We can get the chest X-ray, we can get the UA, but the high yield is to figure out what's going on in the abdomen itself. Because if it is easily accessible phlegmon or soft tissue abscess, then ID can come, they can directly aspirate it, and then we will come to know that which organism that is. So that would be the next step. And now maybe I can pass the mic to Şeyma to tell us more what she makes of the CMP.
So first of all, I love your reasoning. So what we see for the basic metabolic panel, the electrolytes seem unremarkable to me. We just see the patient has an elevated creatinine. We know that this patient has a CKD, but we see that the albumin is low. So for low albumin, I usually ask myself, so is there any kind of protein losing enteropathy? There could be any. I don't assume that there is any liver issue here because we have normal liver LFTs, so liver disease or kidney disease. And also we know that albumin is a negative acute phase reactant, so any kind of inflammation can also cause low albumin. And what I have, but the thing is, since the patient doesn't seem to have any kind of edema, for me, the liver, kidney, protein-losing enteropathy make the hypoalbuminemia less likely. I would have rather think that this is due to the inflammation. And for still, because we're thinking that there's an infectious process ongoing that might affect the skin and the CNS, I was also trying to find some categories. As you say, gram-positive, gram-negative rods, less likely because they usually are fulminant. So I was thinking, and also with the immune suppressant regimen, I was also rather thinking of atypical organisms, so fungal disease. So I don't know where this patient is living, but was thinking of endemic mycosis, also crypto, and also TB. I don't know whether actinomycosis can do it like this, but I still keep that in mind. And yeah, so also mucor and aspergillus. Usually when I hear of abscess, also nocardia comes into my mind, but since I would have expected a more fulminant picture, so I am excited what more labs Amal is going to give us.
Okay, so I'll give some basic imaging. So CT abdomen pelvis showed 4 centimeter right lower lobe mass, 3.7 centimeter enhancing mass in the right abdominal wall musculature, and then 3.7 by 1.7 centimeter lesion at the inferior lateral aspect of the right hepatic lobe with an enhancing lesion and at least 2 sub-centimeter low density liver lesion present. And then CT chest showed 4 by 4 centimeter solid mass in the right lower lobe of the lung and areas of ground glass attenuation. CT head with and without contrast showed multiple enhancing intracranial lesions concerning for sites of intracranial metastatic disease and or septic emboli.
I just have a clarifying question. These enhancing lesions, were ring enhancing or just pronounced as an enhancing?
So the radiologist said just reported enhancing without specifying.
Okay, so first of all, seeing this we have several masses that are like in several organs, just without just summarizing in the abdomen, in the chest, and what it seems to be in the brain. One of the few organisms that also comes into my mind causing this is also something like Klebsiella. So that's something that I would definitely put into my mind. So something like the hypervirulent strain of Klebsiella. This mass that isn't, yeah, that described. With these, we see that there's areas of ground glass attenuation. So generally, when I think of GGOs, this is very unspecific. Could be pus, blood, water, cells, protein. But I have to say, I still want to think, because it's very pretty enriching aliquot, and I want to listen what Kirtan is going to say. Then I want to add my thoughts.
Sure, Shema. So I agree with what you were saying, that we want to know whether they are ring enhancing or not. And first things first, let's tackle the abdominal part. So as we were emphasizing from the beginning itself, that we want to know where is the anatomic structures and what are involvement. So we figured it out that maybe something is coming from the abdominal wall, and it is reasonable to assume that maybe that's the same process which went to liver, went to the lungs, and then went to the CNS. Now, before going into the differential diagnosis of individual entities, first we want to take a step back and ask ourselves that, are we dealing with infectious process or non-infectious process? This could be non-infectious for sure, because although patient is presenting with complaints of 1 week, but who knows that maybe the patient had lesions in the brain for a longer period of time and they are just manifesting. So the time course can be tricky to establish. But if we imagine that this is a straightforward case and not a complicated one, then we would say that it's less likely to be non-infectious causes. So for example, autoimmune conditions like vasculitis, which could do this, GPA, things like that, probably less likely. Same way, could this be lymphoma? Sure, it could be, but if we believe the time course, then probably less likely. So let's assume that this is infectious, and then we can, of course, revisit the hypothesis. And if it is infectious, then I agree with what Shema was saying, that we are dealing with infection, which is probably crossing the tissue planes. So it started in the skin, then went to the liver, then went to the lungs, and then to the CNS. And they always say, that medicine is very descriptive. And if we use the descriptive terms, then we will get to the right diagnosis. So for example, if I say that, this person has rapidly progressive glomerulonephritis and has so-called pulmonary renal syndrome, then we would immediately think about few diagnoses. So similarly, in our case, if you think about it, our patient has what is classically known as pulmonary CNS syndromes. Like if we have involvement of the lung parenchyma and the CNS parenchyma, then what are the entities which can do that? So actually, let me steal one of the tricks which Rabi does. Rabi, always shares the schema. And fortunately, I have one schema regarding the immunosuppression, that what medications people use and what are the bugs it predisposes to. So let me try to share my screen. Okay. So friends, can you see my screen? Perfect. So as you can see, this is the schema which I created of acquired immunodeficiency. So based on which aspect of the immune system is involved, whether it is B cell, T cells, NK cells, neutrophils, plasma cells, or individual cytokines, you can have predisposition to different infections. So in the top part, I have different cytokines, which is a little bit rare. So let's move to the more common aspect. So if you see, first thing I have is the neutrophil defects. So if you have neutrophil defects, then you have predisposition to the normal bacterial flora, invasive candida, and molds. And what are the conditions which will predispose you to neutrophil defects? So you can see that hematologic malignancies, leukemia, or stem cell transplant. So our patient doesn't fit this category. Then we move to the second part, which is the B cell defect. So if we have B cell defect, let's say due to hypogammaglobulinemia, so if this patient was on rituximab, then I would think about it. But MMF doesn't impact the B cells. So we would keep out this category. Then we come to the T cell defects. And this is the part which we should focus on. So if you see the causes of T cell defects, then the most common is, of course, HIV. Our patient doesn't, we will like to know what is the HIV status of our patient, of course, down the line. Is the patient on TNF alpha inhibitor? So that's a no. Does the patient, is the patient on high dose steroids? Doesn't look like that. But then we come to this part, cyclosporin, tacrolimus, and MMF. So both the agents, MMF and tacrolimus, will predispose you to the T cell immunodeficiency. And now if there is T cell defect, then what are the infections that you can have? So here in the parentheses, as I have highlighted, so first is atypical bacteria. So as Şeyma was saying, that what are the bacteria that we think about? So for example, actinomycosis, definitely. Then nocardia as well, because nocardia also lives inside the cells, and T cells are instrumental to eradicate the nocardia. Then we go to Legionella, Listeria, some viral infections like HSV, Cryptococci, and PJP. So now we have like did the autopsy of our case, that we tried to figure out that where is the immune system defect, how can medications predispose it. So now we are thinking that maybe out of all these 5 to 6 bugs which I highlighted, maybe one of them could be the potential answer. And is there any way to make further progress? So I think maybe I will ask Şeyma to share her insights as to, depending on the distribution of lesions in the CNS, what kind of organisms we can prioritize.
So first of all, I know that one of the most common causes for brain, lung, skin lesions is always actually nocardia that I'm thinking of. So that's one of the few things that I would like to rule out. And we see multiple enhancing lesions. So yeah, and with this septic emboli, so I'm still not ruling out fungal infections, being honest with you. So something like Cryptococcus is also still in my mind, and also endemic fungal diseases. And I would still also think of a TB. So, but I have to say, with these multiple abscesses, I rarely associate it with TB, being honest with you. So fungal nocardia is like my priority at the moment. So that's why I would like to get, some fungal studies like 1,3 beta-D-glucane, also galactomannan, also blood cultures. And also what everyone mentioned is like within this patient, we also have to rule out infective endocarditis if we see this multiple enhancing lesions within the brain. So always rule out infective endocarditis. And so do TEE, TTE, TEE. Yeah.
Okay, so I'll give some, so we did an LP, and the LP showed glucose of 85, protein 243. The fluid was colorless, and nucleated cells were 165, red blood cells 2,993, neutrophils 71%, lymphocytes 8, monocytes 21, and that's it. And then, so for the urine histo, it was negative, AFP was negative, and then palm was consulted. They did a bronchoalveolar lavage, which showed cell count of 100, ciliated epithelial cells of 3, eosinophils 3, lymphocytes 18, neutrophils 64, and squamous cells 12. And then biopsies were taken and showed amyloid deposition and areas of necropollulant debris. Anything else you guys want to know?
I think this is good, Aman. Maybe in the next record we can have more data. Yeah, thank you. So maybe I can try to tackle the CSF findings, and I will ask Şeyma to take care of the BAL findings. So in the CSF, the first things first, we usually try to make sure that the opening pressure is elevated or not elevated. Fortunately, in our case, when we did the imaging, there was no concern that there is hydrocephalus or like a big mass which is compressing the ventricles. So opening pressure is not that relevant in our case. Then we go to the cell count. So as you can see, that patient does have some nucleated cells and they were neutrophilic predominant. So that makes us wonder that is this actually the bacterial process? And I think we discussed about this in the VMRs before, that when you find the neutrophilic pleocytosis, then apart from the common bacteria, that's a gram-positive and gram-negative meningitis causing organisms, what are other considerations? So if we take step by step, first thing, could this be amoebiasis? We should always ask this question, that whenever you have the CSF profile, which looks like bacterial meningitis, but what if it is not bacterial meningitis? Then we think about amoebic meningoencephalitis. So things like Naegleria and acanthamoeba. Now, in our case, those hypotheses are less likely because these infections usually happen with a specific epidemiologic exposure to like the freshwater swimming, and usually immunosuppression has no impact on this kind of evolution in the CNS. And also the ring enhancing lesions in multifocal region and the skin involvement is inconsistent. So we can put that hypothesis to the aside that this is less likely to be amoebic. If we move to the next category, then we come to the atypical bacteria. And in that, nocardia and actinomycosis are important because if you look at the people who have nocardiosis and their CSF profile, almost all of them looks like bacterial meningitis. Like some of them even have low glucose. In our case, glucose is normal, but I have seen that how this can lead the team to go down the wrong path, that you start people on broad spectrum antibiotics, ceftriaxone, vancomycin, all the good things which we give, and still the patient will keep on getting worse. Because as we know that nocardia is unique and it will respond to Bactrim, not to the ceftriaxone, not to the vancomycin. So this realization that you can have bacterial meningitis-like profile with nocardia as well is important. And then there are some other rare organisms like even Brucella can cause bacterial meningitis-like pattern. But again, the time course, like brucellosis doesn't present like this. It doesn't cause like such kind of abscesses in multifocal region, and definitely not in the acute phase. So our mind is more in the category of bacteria and atypical bacteria. And then maybe I will ask Şeyma to tell us more about the BAL findings.
So I have to say with the BAL findings, we see that there's lymphos and neutrophils, so it's mixed. And I have to say it's not a lot telling for me, just telling me, okay, there's some kind of inflammation going on, because especially with this neutrophilic predominance. So I'm also concerned of something bacterial. And the amyloid deposition is maybe just due to because this patient had amyloid, which can also present like amyloid is notorious for presenting as far as I remember, with diffuse cystic lung lesions from what I've learned. And otherwise, what I also wanted to mention with this neutrophilic pleocytosis, I have to say, I don't know for how long this patient was having this neck pain. I just read recently an article in New England Journal that mentioned that the most common cause for persistent neutrophilia in the CSF studies is nocardia, as you mentioned, but we also have to think of TB and candida, and another rare cause, like if it's a chronic process, is also something like NMOSD. So yeah, I'm excited what is coming next.
And since I think we have time, maybe I can ask Şeyma and even the group to share in the chat that given that we are at this stage of the case where we are thinking that maybe we are dealing with atypical infection, which has disseminated from the skin to the liver, lungs, and CNS, what is the next best way to move ahead? We already have some basic microbiologic data. And what do you think will be the high step? So maybe I can ask Şeyma as well if she has some thoughts. And meanwhile, we wait for the group to write in the chat.
So for me, I would definitely want some blood cultures as well. Also a heart echo. And if there, I don't know, also whether they did a biopsy of one of the lung lesions, for example, you can do bronchoscopy and a transbronchial biopsy of that lesion, and also do cultural gram stain and also PCR. That's something that I would do. And let me think. I just wanted to mention also, because I love that Andrew mentioned this, with these multiple abscesses. I don't know whether this fits, but he also mentioned the strep anginosus bacteria that are very notorious for causing abscesses. And there's a mnemonic that I remember from Sammy that is called CIA to remember these bugs: constellatus, intermedius, anginosus. So if you have multiple abscesses, also think of the strep category. But yeah, that's what I would do, Kirtan. And you?
Perfect. I agree with you, Şeyma. And you know, the best thing I like about Şeyma is that she remembers all these mnemonics. Like, I'm sure that Sammy shared this mnemonic, like, I don't know, 5 years ago in some remote VMRs, and Şeyma will still remember it. So, like, that's so impressive. So, yeah, I agree with Şeyma that first things first, we want to make sure that we are not dealing with like Klebsiella or like strep, which are like the classic bacterias. And the best way to rule that out is by getting the blood cultures. And usually, like I have seen that people who have strep anginosus bacteremia and who have this CNS abscesses, these organisms are like, they are very rapid growths. Like we have seen growths within 4 to 6 hours. it's not like TB that you have to wait for 6 weeks to grow, especially when you have an abscess, which could be from strep anginosus. So blood cultures would be high yield. And if they are negative by 2 or 3 days, then with a reasonable high amount of suspicion, we can say that we have ruled it out, because so far Amal has not told us that patient is on any antibiotics. So there is no reason to suspect that cultures will be false negative. TTE, of course, we want to rule out the infective endocarditis. And I think Jimena shared beautiful thought earlier on that could this be Lemire syndrome, that people can have septic pulmonary infarct as well. And that's a good thought. Now, only the reassuring finding is that patient has no antecedent sore throat pharyngitis or neck pain to suggest that, so which is good. And then I'm saying in the group, Mengyu mentioned that how strep group can do this. So definitely we'll get the blood cultures. And maybe the next step I would say is getting the tissue, and which is the best way to do that. For example, if we are saying that this is atypical organism, then by definition we are invoking the hypothesis that cultures probably won't be that helpful. Like we know that even people who have, let's say, all this endemic mycosis, they don't grow well in cultures. Same way nocardia is like hard to grow in the cultures unless like you are in frank sepsis. So the best way moving ahead is that once we get the basic cultures, probably the tissue, and which is the easiest tissue to biopsy. So it looks like that patient is in substantial pain from this abdominal mass, and we don't have any suspicion that this abdominal mass is making fistulous connection with the internal organs, and biopsying it will cause any further damage. So it seems to be well contained, at least in that region. So we can try to biopsy the lesion, and then we can do all the staining. So as Şeyma mentioned, we will do the gram staining. We will do the acid-fast bacilli staining. And AFB staining is important because what if you find the AFB stain positive, but rather than seeing the classic morphology of mycobacteria, you see like the rods and stuff. And then you will think more about, could this be nocardia? Because nocardia are AFB positive on the staining. So I think getting that tissue is going to be the instrumental.
So, okay, guys, so the final LCOT will reveal the diagnosis. So do you guys want me to proceed?
Oh, okay, wait. In that case, maybe I will ask Şeyma to tell that. What do you think, Şeyma? What's your final bet?
I would actually go with nocardia, if I'm being honest. I mean, it totally fits. This patient has, as you said, an impaired T cell immunity, is prone for atypical bacteria. We see this disseminated spread of what seems to be multiple abscesses, and yeah, the most common things being common, think of nocardia, especially if this patient also is having contact to soil, because nocardia is as far as I remember, it's a rod that is yeah, especially if you are exposed to soil, you yeah, are prone to it. What do you think, Kirtan?
No, I agree with you, Şeyma, that maybe we can take that approach, that patient has T cell immunodeficiency, and all the organisms that we mentioned, maybe we can go from the least likely to most likely if we analyze it. So let's first say that, okay, if people have T cell immunodeficiency, they are predisposed to viruses, like let's say herpes group of viruses. Now, in our case, as we know that this patient has abscesses in the liver and in the lungs and in the brain. So that is very inconsistent with any herpes group of viruses. So we can rule that out. Then we go to the fungi. So we talked about PJP and endemic mycosis, right? Now, PJP will have classic signature in the lungs. And what we saw in the lungs is that there is a right lower lobe mass. Now, PJP will tend to cause diffuse GGOs, and PJP doesn't affect the brain in this form. So that makes it less likely. Then if we go to endemic mycosis, now endemic mycosis is a fair game because as we know that blastomycosis, histoplasmosis, all of them can cause skin lesions and CNS involvement. The only problem is that the time course, that if we believe this time course, then probably the patient didn't have a long enough exposure to cause this. So we can rule the endemic mycosis out. Then we go to some atypical bacteria like Legionella or Listeria. Again, the same thing. The Listeria can definitely cause rhombencephalitis, but it doesn't tend to cause such discrete abscess formation in the liver. So that makes it less likely. If you think about Candida, which Şeyma was telling us about, then Candida, if it's disseminated in your bodily fluids, then we call it as candidemia. And that is more common in people who have neutrophil defects. In people who have T cell defects, usually you get like mucocutaneous candidiasis, not this invasive candidiasis. So that also rules it out. And then finally we come to these two bugs like actinomycosis, nocardia. Now, is there any way to say that it could be one of them? To be honest, no, it could be both of them. It could be one of them. But at least for actinomycosis, the classic teaching is that if you have a lesion on the skin for a long period of time, then eventually that skin lesion ruptures and you see the evidence of this sulfur granules coming out. Now, I know that that is the textbook picture. That doesn't happen always, but at least that is something which we didn't see in our case. And also actinomycosis, if it goes into lung, and it's more likely to cause cavitary lung lesion. We don't have that. So all these factors make me think that maybe the most likely answer is nocardiosis as well. But of course, I'm keeping my mind open to stay humble, making sure that I didn't miss any other endemic mycosis or actinomycosis. But yeah, that will be my next step, Amal. So maybe the 16S RNA sequencing of the sample which we got from abdomen, that could reveal the answer.
Okay, so I really enjoyed your discussion. It was very impressive, honestly. So the CSF culture grew partially acid-fast bacilli, suggesting nocardia. So you guys are right. So the final diagnosis was disseminated nocardiosis.
Perfect. And Amal, can you tell us that how was it like for you to take care of this patient and how did the patient do in terms of management?
So the patient ID was consulted. They transitioned antibiotics to imipenem and linezolid, and patient like recovered, was in full remission after. He was doing well. We saw him in clinic after, and he was like completely treated. So he did really well after. He received like 6 months of antibiotics, if I remember.
Wow. Yeah. Excellent case by Amal, like so humbling that how can patient present with abdominal pain and then end up having this weird infection. And I do remember that there is this one beautiful podcast, like Febrile podcast. I'm sure that Yes and other ID lovers know about this podcast. So there was a case of nocardiosis in this podcast. And in the end, the management was the part which was like very challenging for me to understand and remember, because they always say that, let's say if somebody presented just with pulmonary nocardiosis, then should you image the brain in case if patient has no symptoms? In our case, we had tremors, so we had a reason to do the brain imaging. Let's say if somebody just present with skin and lung involvement, should you image the brain or not? The reason is because if you find a lesion in the brain, then does that mean that your therapy needs to be extended or not? That's the question. So from what Amal told us that the patient was treated for 6 months, that seems fairly long. Like if it was just lung or skin, probably people would do like 3 months or so. So I think that's a burning question, that should we always image the people who have nocardiosis, and what's the ideal duration of treatment? What do you think, Shema? What's your takeaway from this case?
I have to say I've taken a lot, like seeing how the case started with abdominal pain, neck pain, and it came up to be an ID case. I really loved it, Amal. I learned so much from it, and also again, it really helps me with reasoning. Again, with I have to say, like, if I had to summarize the most important teaching points for me again, because I really love if we have this immunocompromised patient. There's the approach what Kirtan told us. If you have a B-cell defect, think of encapsulated organism. If you have something with the neutrophils, think of especially bacteria that are within our body, like within something like Candida. So these the bacteria that are colonizing our bacteria fungal that are colonizing us, and also with the T-cell defect, think of intracellular organisms, and also TB, PJP, and nocardia.
Perfect. Thank you so much, Shema, for summarizing everything for us, actually. So now maybe I will pass the mic to Jimena to share the teaching points.
Thank you so much for this discussion. When I saw that you guys were going to discuss a case, I was just like, this is a no miss VMR. So I'm really glad that I was able to be here and learn from you guys. We have a lot of teaching points, but I'm just going to try to highlight the most important ones. I think that we can organize the knowledge according to how you wrote down the case. And then just remind you guys that with abdominal pain, we can also rely on the BIPO mnemonic, but it's also important to rule out life-threatening causes. And it's also very helpful to identify the origin of the pain, kind of think about if it's coming from the abdominal wall, if it's coming from other inner or deeper structures. And when we have neck pain and coordination problems, we can think about potentially the basal ganglia and the cerebellum being involved. The time course in neuro, it's always going to be very helpful when you have an acute or subacute time course. We can think about infection, toxins, or metabolic causes. And then you guys also shared this huge medication perils with the tacrolimus, which is a calcineurin inhibitor, and the side effects that we can have, which are cerebellar toxicity and also renal toxicity. We got to remember that this medication predisposes patients to have T-cell defects, as they mentioned, and that can also point us to having other microbiological causes like HIV, Listeria, Legionella, and nocardia. Another really good teaching point was to think about if the ataxia is diffuse or not. Usually when we're dealing with medications, ataxia is diffuse unless we're dealing with metronidazole, that can cause focal ataxia. And also remember to think about the medications that the patients are consuming, because that might make them immunosuppressed. And then because of that, we're not going to be able to see what we expect in the physical exam, like fever. And despite that, that if we don't have it, that's not something that we need to like rule out. And then with the tests, we got some keys to having low albumin. We can think about more organic causes when we have the protein-leucine enteropathy, liver and kidney diseases. And Şeyma also told us that usually that's going to be associated to edema. And if not, then we can think about the low albumin being low because of chronic inflammation, acute inflammation. And then lastly, with the LP, we can also check two very important parameters that are the opening pressure and then the cell count. And Kirtan gave us like really nice causes of the neutrophilic pleocytosis, which are going to be the normal bacteria. We can also think about amoebas and other atypical bacteria. In this case, we had nocardia, which was consistent with the finds that we found in the LP. And that's all I have for you. Thank you so much for this discussion. It was a pleasure to be writing the teaching points for you guys.
Thank you so much, Jimena, for amazing wrap up. And I must say that it was very efficient. Like there was so much data, the scribing was efficient, teaching points were efficient. Şeyma discussed it efficiently. So we are completing it with the right time. Like this complex case, and we are still completing with 5 minutes left. So that's so good. Thank you so much, Amal, once again for bringing this nice case. And I was just texting in the group that this is a fantastic debut. That you start with disseminated nocardiosis, we know that the sky is the limit now. So thank you so much for that. And thanks to Yusuf once again for giving me the opportunity. And it pleasure was all mine with Şeyma for this first time discussion with us. So thank you so much, learned a lot. We'll read more about nocardia tonight and we'll share something new if I find. But thank you so much, friends.
Bye, everyone.